talk for the next 30 minutes very quickly about the right ventricle and about pulmonary hypertension. This is maybe a little bit more of an advanced talk, but I hope that even those who don't have experience doing this type of assessment, they can appreciate when they read cardiac echoes, how the cardiologists and echocardiologists, what their language is and how they are assessing the right heart. So the right ventricle, I've often referred to as a neglected chamber, just like the AVR lead of EKGs, because we often just spend so much time looking at the left ventricle. How does the left ventricle contract? How is the left ventricle dilated, or how does it relax? That we often kind of don't think about the right ventricle. But right ventricular failure is an extremely cause of almost all your symptoms that you're seeing in the emerge: shortness of breath, syncope, if they come in with edema or any chest pain. Think that the RV is also as important a cause of these symptoms as the left ventricle. So the main pathology that I want you to think about is, could this patient have pulmonary hypertension? Could this patient have a pulmonary embolism? Is there an RV infarct? Is there some sort of RV cardiomyopathy that's causing RV failure? So the objectives for the next 30 minutes are for you to understand how to ask yourself 3 questions on your patient. Is your patient's RV dilated? Is the RV functioning normally? And is there evidence of pulmonary hypertension? So those are the 3 main questions you want to ask yourself when you're assessing the RV. So a couple basic concepts to understand the RV before we go into some of the details. So first of all, the anatomy. As you all probably already know from your anatomy and your echo, is that your left ventricle looks very cylindrical, looks like a bullet, and it's very symmetrically shaped. Whereas the RV is shaped more like a crescent. And as a result, the RV assessment is a little bit more complicated. But just so that you understand how the shape and the anatomy of both chambers differ. The other thing is, because remember that the left ventricle has to contract against your systemic pressure. So someone who has a heart rate or blood pressure of 150 over 100, that left ventricle has to contract against that systemic resistance. Whereas the right ventricle has to contract against a much, much lower pulmonary vascular resistance. And as a result, the right ventricle is always going to be smaller than the left ventricle. And also the muscle contracting at the RV is always going to be much, much thinner. So one of the measurements I'm going to be talking about is that the free wall of that right ventricle should always be less than 5 millimeters. And that's because the RV doesn't have to contract as strongly throughout every contraction. The other thing you'll also realize, and I'll show you a video, is while the left ventricle, when it contracts, it will contract in a sort of back and forth motion, whereas the right ventricle, when it contracts, primarily contracts in an up and down motion. And so when you see a patient, or when you do a 4-chamber view, you'll notice that the left ventricle is really contracting inwards, back and forth between the sides, whereas the right ventricle is doing a lot of this up and down motion. And so we have to assess that motion as part of our assessment of the RV, overall RV function. So how do you scan the RV? Well, contrary to the left ventricle, where a lot of information can be obtained from the parasternal long axis, to look at the RV, you really do need to know how to scan in all the ways that we have taught you. So you need to know how to do a good parasternal long and short axis. You know what? You should, of course, already know how to do a subxiphoid. But by far and away, the best view to look at the right ventricle will be your apical 4-chamber view. And we'll talk about what that RV focused view looks like. So you really do need to know what all of these views are. So remember that this is your classical parasternal long axis, where you have your left ventricle, which is what you've always been focusing on for function. But you also need to look at that right ventricle, and there's some aspects of that right ventricle that you want to look at when you're assessing during your parasternal long axis view. Your parasternal short axis, again, we were always teaching you that the short axis is a very good way of assessing for regional wall motion abnormalities of the LV, as well as the amount of contraction. But in this view, you, as I will talk about, is also very good at assessing for evidence of pulmonary hypertension and by giving an idea of what's going on with the septum. And again, I'll talk about that. As I mentioned, the most important view of the heart to assess the RV and its multiple aspects is the apical four-chamber view. So in this view, as we're going to discuss, this is how we're going to discuss the size of the ventricle, how it's functioning, and if there's any presence of pulmonary hypertension. But as I'm sure some of you who do apical four-chamber views notice, is that once you're focusing on your left ventricle, you're often just unable to get a good view of the RV. And so what I would say is the next step is that once you've assessed your LV, now focus on the RV, and that is by sliding your probe a little bit more laterally, rotating slightly and aiming up back towards the right shoulder. And what you're going to obtain is what's called an RV-focused four-chamber view. Okay, it's on its side, and the left ventricle is no longer in the center of the screen, but you don't care about that anymore because you're now focusing on that right ventricle. So this is an example of a four-chamber view on the left that's normal, that you recognize easily. And here's your RV-focused apical four-chamber view. So first question, once you've optimized your views of the heart, your first question is the RV dilated? So when you have a parasternal long axis, we've been talking about the fact that you can just get an eyeball idea of whether the RV is dilated by assessing the size compared to the aortic outflow tract and the left atrium, and they should all be more or less the same. So it's about a one-third view of these areas. And if you see that, you have an idea that the RV doesn't seem very significantly dilated. If you give an example of this case where that RV is clearly bulging and much, much bigger than the aortic outflow tract or the left atrium, you're already getting an indication that there's something wrong with the right ventricle. The next question is that you may want to have a sort of a quantification of the RV. And so this is where the echo literature talks about having some specific measurements to assess the RV compared to its normal size. So once you get a good image of your apical four-chamber view, there's three specific measurements that are mentioned in the echo literature. First, you can measure at the annulus of the tricuspid valve, and from the septum to the lateral wall, should always be less than 4 centimeters. If you climb up to the mid-ventricle, and again, this is always at end diastole when the ventricle is at its largest, just before it contracts. The mid-ventricle should always be less than 3.5 millimeters. And the final measurement that you can measure is from the apex all the way down to the annular plane where the tricuspid valve is, and this should always be less than 8.5 centimeters. So if these measurements are much larger, then you are already questioning whether or not that there is actually some RV dilatation. So some causes of some miscalculation or some RV dilatations, obviously if you have poor measurements and you don't measure correctly, that's probably the most important cause. But as we've talked about any of these other indications, any pulmonary hypertension, significant tricuspid regurg, an acute or chronic pulmonary embolism, some dilated cardiomyopathy, or an RV infarct will all acutely dilate the RV. So now that you've answered your first question, or you asked yourself your first question, is the RV dilated? The next question is the RV functioning normally? And there are many, many ways in the cardiac literature as to how to measure RV dysfunction. But by far the simplest one, and the one that's probably discussed most in the emergency department, is the use of what is called TAPSE. It's a long name, tricuspid annular plane systolic excursion, and we'll talk about what that means. So if you remember when I said at the beginning that the RV moves much more in an up and down motion. So the TAPSE is a measure of the actual distance that the free wall right at the tricuspid annulus moves in an up and down direction. Normally, it should be at least 1.5 or 1.6 centimeters. Now, using the centimeter markers on the right, most of the time you can just eyeball it and say, well, this is a very vigorously moving TAPSE, and this RV function is normal. And if you can measure between that and this TAPSE, where this is at the tricuspid annulus right here, Yes, it's moving quickly, but it's not moving very much. So here already you can tell that there is some RV dysfunction going on in this patient. Again, eyeballing it is important to get a first sense as to what you want to see on this patient. But if you want to measure it, this is where you can start to use M mode for those who have done it in the past. What you'll do is, again, you'll get your good image of your right ventricle. You're going to place your M mode cursor right along the that it crosses where that tricuspid annulus is. And then you'll press M mode again, and you'll get this time lapse image on the bottom. And then you'll just use your calipers and measure. And here the distance with this patient's TAPSE was 1.8 centimeters. Clearly, this is a normal RV function. Compared to the second video that I just showed, where I looked at the TAPSE, and this was less than 1 centimeter. So this TAPSE might be moving quickly, but it is not moving very much in terms of distance. And this you can have a conclusion there is some RV dysfunction. So knowing about RV dysfunction is very, very important in your critically ill patients. If you see patients that are hypotensive or intubated in your emerge or in the ICU, this gives very important management decisions on how to give fluid, what your vent settings should be, if and when you should be using pressors, and of course, for those in the ICU, whether or not there are any surgical options to suggest. But these are really important to guide management in those patients that are very, very sick in the emerge. It also shows that in patients who have proven pulmonary embolism, to assess RV dysfunction does provide some prognosis in terms of overall health of the heart going forward, as well as predicts death. So if someone comes to the emerge, you've scanned them, you've had a CT scan, and they have a pulmonary embolism, go take a look at what the RV is doing. And the TAPSE can tell you or give you an indication of whether this person has RV dysfunction due to this PE. This might be an indication to give TPA, but it does give prognostic information. All right, so finally, the last part is what I think is the most the most sophisticated question, and is whether your patient who presents with shortness of breath or edema or a syncope, is there any pulmonary hypertension in your patient? So what is pulmonary hypertension? Remember that the mean systolic pressure in a normal patient is going to be anywhere from 80, 90 to 100 millimeters of mercury. And that's why the LV is so thick. But normal pulmonary vascular resistance or pressures will be anywhere from 11 to 17 millimeters of mercury. And so pulmonary hypertension is defined as anything greater than 25 millimeters of mercury, and this is what needs to be assessed. In terms of the causes of pulmonary hypertension, those who you see all the time in the emerge, a huge majority, 90% of pulmonary hypertension cases are due to either left heart disease, so systolic function, diastolic dysfunction, or valvulopathy, or lung disease, such as COPD or interstitial lung disease. A very small amount, like 10%, are those idiopathic pulmonary arterial hypertension cases that we often see, and that we're not sure how, we're always a little bit hesitant to know how to treat. But the huge majority of patients who will have pulmonary hypertension are due to cardiac and lung causes. So there are, as I mentioned, multiple symptoms of pulmonary hypertension. And if you don't think about it, you can have a delay in your diagnosis. And as a result, you can sort of delay the management of these patients if they are sent home and not managed appropriately. Oftentimes, a chest X-ray and EKG are done. Now, an EKG can show some evidence of right ventricular hypertrophy, but it's not a sensitive test. And similarly, chest X-rays are done commonly, but it's not a very sensitive test to rule out evidence of pulmonary hypertension. So that's why we do echoes. Remember that the way of assessing this is that you can do it qualitatively. You can just take a look at your 2D image, and that's your first way or approach you should do this. And so the first two things you want to look at is there any evidence of RV hypertrophy? And then second, you want to look at whether that interventricular septum that I spoke about earlier this morning is flattened. So let's look at those two. So as I mentioned, that right ventricular free wall, because there isn't very much pressure that a normal right ventricle has to contract against, doesn't need to be very thick. As time goes along, as the pressures inside that right ventricle increase, that free wall of that right ventricle have to become hypertrophy and have to become thicker. So you want to measure very close to where the tricuspid valve is, the thickness of the free wall of the right ventricle. And it should be always less than 5 millimeters. Now, the most important sort of caveat is make sure you assess whether this person has any epicardial fat, so that you don't include that in your measurement, because clearly you're going to have a falsely thickened right ventricle. So if you look at this image compared to somebody like this, who has a much, much thicker right ventricle, already you know in the right ventricle that there is some sort of high pressure system going on in the RV. And as I mentioned, looking at the parasternal short axis, you want to look here at the septum. Now, the image on the left here shows a nice circular donut contracting in all the axes, showing that this is a healthy-looking LV, and there doesn't seem to be any external forces from the right ventricle. But if you look at the image here on the right, where you can clearly see this D-shaped image where there is some pressure, high pressure from the right ventricle pushing against that interventricular septum, clearly this is giving you an indication that something is going on. There is either volume overload or a pressure overload from the right ventricle, suggesting something bad going on in the right ventricle. And so that should be one of your first qualitative ideas that something is going on. Now, those are your qualitative sort of 2D assessments. If you actually want to start to measure the actual pressure or the presence of pulmonary hypertension, you can use actual quantitative measures. Now, the only real way that is done is cardiologists send these patients to the cath lab, and those are the two ways of that's the actual way of measuring the evidence of pulmonary hypertension, the actual measurements. But we can estimate it by doing some quantitative analysis or assessment in the emerge. So the first thing you want to do is to assess the velocity of your tricuspid regurgitation, and I'll talk about that. And your second assessment is to actually measure or estimate the pulmonary arterial pressure in the pulmonary vasculature. So first thing is you have to do is obviously get a very, very good image of your apical four-chamber view. Once you get that, you want to have a color box that is right over your tricuspid regurg, okay? Now, why do I say it has to be over your tricuspid regurg? Now, you have to remember or know, tricuspid regurg is an extremely common finding. In fact, I think 70% of people with normal hearts will have some sort of evidence of tricuspid regurgitation. And in fact, I think some of the echo people, they measure how good the machine is and how good the technician is by your ability to identify and find patients with tricuspid regurg. So the presence of tricuspid regurg does not really indicate any pathology because it's such a common finding. So once you've got your box around your tricuspid valve and you see your tricuspid regurg, which is this blue wave going back into the right atrium, what you're going to want to do is put your continuous wave Doppler, which some machines will do automatically. As soon as you press the continuous wave Doppler, when you have your color blocks, you will get an image like here on the right-hand side, where you will have this negative deflection jet, which is a jet of blood moving away from the probe, which is where tricuspid regurg, the direction of tricuspid regurg. And you see at the very, very bottom of that is you're going to be your velocity, your maximum velocity of your tricuspid regurg. So what you're going to see here, and that's your continuous wave Doppler image of your tricuspid regurg, is that you have these negative deflections. And what you're going to do is you're going to simply place your cursor and find your maximum velocity of that tricuspid regurg. So 355 centimeters per second or 3.55 meters per second. That's your important information that you need to determine. So a normal TR velocity okay, so velocity we're talking about, is anywhere between 1.7 to 2.3. So I would just say, 2 plus or minus. So if your TR velocity is less than 2.8 meters per second, you can already say that pulmonary hypertension is unlikely in these patients, and we really can move forward on that. Now, I think last year I gave a talk on tricuspid regurg and how to assess severity of valvulopathy. Severe tricuspid regurg is measured by the amount of blood that you see on that color flow Doppler, and how much of that blood goes into the right atrium. The severe tricuspid regurg does not imply pulmonary hypertension because it's the velocity, how fast that blood goes back into that right atrium, which is a determinant of a high pressure. So that's what's important. If someone has very severe TR, that doesn't mean that they have high pressures. So here's the example of the other case of a patient that, here your tricuspid regurg jets, and where your maximum velocity is almost 4 meters per second. So already you have a suggestion that there's something going on, that there is a potential likelihood of pulmonary hypertension in this patient. So how do you actually estimate the actual pressures? Like I said, it's usually done in the cath lab, but you can estimate your pressures by estimating the systolic pulmonary artery pressure, or what's also known as the right ventricular systolic pressure. I'm going to show you this equation, not because I want you to memorize it, but just to give you an idea of how it is used to estimate the pressures. So the pressure is the velocity at TR max that we just had, so around 3.9, so 4 squared multiplied by 4. And then there's this other measurement that you have to take into consideration, plus right atrial pressure. And the reason why I'm saying that is that you will read a lot of echo reports when they look at the evidence of pulmonary hypertension. They will always have that assumption of what the right atrial pressure is. So what do they, or how do they measure or estimate the right atrial pressure? Well, the right atrial pressure is estimated on looking at the IVC. And the two things they want to look at is they want to look at how much that IVC collapses and what is the actual size. And so with those two measurements, they will add on some extra pressure to your estimated calculation. So if your IVC is less than 21 millimeters and it collapses very, very easily, then your RA pressures are basically estimated to be normal, and they'll just add 3 to that calculation. If your IVC is very dilated and it also does not collapse when you take a sniff, then you assume that your RA pressures are very high, and therefore they're going to add 15 to that measurement. Anything in between, they will assume that the RA pressure is intermediate, and they will add 8 to that calculation. So let's go back to the case that we just saw. So here is your patient that you've done a good continuous wave Doppler image. Your velocity is 3.55 meters per second. Okay. You then do your quick assessment of the IVC, and you can see that the IVC is not very thick and it collapses quite well. So how are you going to measure? You're going to put this into a measurement and see that your systolic pulmonary artery pressure is 53.4. Now, again, like I said, I do not want you to remember this, equation, but if you go to the Canadian Society of Echo website, there is a tab on the top that says calculators. And this is where you will see all the various calculators that will help you, and you will look for the right ventricular systolic pressure calculator. You literally just put in the 3.55, you tell them what the IVC is, and it will spit out the systolic pulmonary artery pressure value. And if there's an online calculator, which I could move on, but I may lose the screen. It'll basically tell you that the systolic pressure in this patient is 53.4. So you have your measurement of your systolic pulmonary artery pressure. So what is considered anything abnormal? So anything over 40 millimeters of mercury is considered mild pulmonary hypertension. Anything over the amount of 50 is considered moderate. And anything over 60 is considered severe pulmonary hypertension. So our patient that we just saw had a calculated systolic pulmonary artery pressure of 53. So we already know that this is a patient in the moderate category. And so we have to see what is our situation. Does this patient have a normal echo from a few months ago, in which case something has happened to that RV to maybe suggest as a cause of this patient's symptoms who presented? Or is this somebody who's known pulmonary hypertension and this is a stable chronic pulmonary hypertension? So this is a lot of information that you can get over and above what you see in the left ventricle. But I cannot stress this enough. If you can't get a good quality apical 4-chamber view and you can't get a good quality TR jet, don't start calculating these systolic pulmonary artery pressures, because your amounts and your calculations will be off. So in summary, RV failure is a common cause of all the symptoms that we see, patients that we see with very common symptoms that come into the emerge. It will be missed if you don't look for it. So again, take a quick look at that patient's RV as well as the left ventricle. The questions that you want to ask yourself very quickly when you assess these patients' hearts are, is there RV dilatation? So take a look at the size of the RV compared to the LV. Is it more than 2/3 the LV? If you want to do some measurements, that's great. Is there RV dysfunction? Take a look at the TAPSE, eyeball it to see if it's very, very normal or some dysfunction. Measure it with M-mode if you want. And then look for evidence of pulmonary hypertension. Again, do it by assessing for RV wall thickness. Look for compression of that interventricular septum. And then if you want to start calculating, which is very one step forward, look at the TR jet. So, like I said, it's very important to diagnose it. It will help or make a difference in your treatment options and your prognosis in patients. And like I said, the stuff you want to see is look for high TR velocities. You want to look at the IVC to see if it's dilated and does it collapse. Does the RV look dilated and hypertrophied, and look at that interventricular septum. Now, I did mention a lot of calculations, but I think what's most important is that you first eyeball the RV, get a sense that if the RV looks normal, TAPSE looks normal, the RV free wall looks normal, you may not necessarily have to go in and do all your calculations. But if you want to go that one step further, absolutely start doing some of your quantitative assessment. And even though some patients come in and you don't think that there is any issue of right ventricular problems, practice on every single patient that you're going to assess the LV, go over to the RV and just practice, even on your healthy patients, to practice recognizing what you're looking for so that it becomes second nature, so that when you do assess your patients who are very sick, it becomes easier for you to do actual measurements on. And with that, I will stop and take any questions.